It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back to the podcast. I am going to discuss an interesting case today, or an interesting approach to a case. But before I get into that, I just wanted to remind you guys of the Virtual Pain Fellowship, which is now live on the NRAP Academy's website. It's basically pain exam with some extra material added to it. You could go to Pain Exam and do the Pain Exam Complete, which is more or less the same thing. However, I do have a newer platform, nrappain.org, where if you go into either the anesthesia, PM&R, or pain regions, you get the various board reviews. On the pain, you have the Virtual Pain Fellowship, and it may just be a more user-friendly interface in terms of if you're looking just to do a month-by-month subscription as opposed to the full year. That being said, if you go to Pain Exam, you get the same content more or less. You might be missing some of the regenerative medicine content, but you'll still get the full board review experience. Anyway, I do have ultrasound courses every month, various locations, as well as private sessions coming up. I have a private session in Canada next week, and followed by that, a potential Eastern Europe trip, which I'll tell you about it if it actually happens, and much more. So please check back with the newsletter. If you're not on the newsletter, go to painexam.com and just sign up, or check out our calendar of events and courses. We do have a regenerative medicine course in November. I hope to see you there. So what inspired this podcast today was a thought I had. If you listen to my podcast and know how I practice pain medicine, I am never in a rush to stick a needle in the epidural space in the cervical or thoracic spine. I do it maybe a few times a month, not many. For a pretty busy pain practitioner, I could be doing a lot more. But the way I cop out of doing these epidurals is by doing paravertebral injections, for instance, the thoracic paravertebral blocks or brachial plexus blocks. And I talk about this all the time. And at the end of the day, the epidurals work really well. I'm not against doing cervical epidurals or thoracic epidurals for radicular pain. It really does work. However, I'd say 80% of the patients usually get away with just a nerve block by itself without needing the epidural. And with the ultrasound, you don't need to stick a needle into the foramen to get a selective nerve root block. You could go distal. You could find the exiting nerve root, and those nerve roots are part of the brachial plexus, right? So when I'm doing treating cervical radiculopathy, many times I'll go to a brachial plexus block first or a selective nerve root block first, not a transforaminal, not sticking the needle in the foramen where the blood vessels are, and which in my opinion is higher risk. So that led me to today's topic, which basically revolves around the patient who presented. He has kind of a pain, more or less, more of a sensation of, he calls it worms, crawling up and down his left side cervical spine. And I did a trigger point when I first heard of this. Then I got the MRI back. And the MRI has significant stenosis at C3 and C4, more or less the dermatomes which he is complaining of. And these dermatomes don't go down the arm, right? So you can have a radicular pain, which can present as an axial pain in the neck when you're talking about the upper cervical nerve roots. So it looks like he either needs an epidural high up or that will spread high up, because I wouldn't stick a needle in the interlaminar space that high. I usually go at C7, T1, maybe a little bit higher with enough volume to reach it, which is one approach. Or you could do the selective nerve root block from the side. But then when I'm thinking, well, is this more C3 or C4? Well, I guess I could do a really thorough neuro exam or send them to a neurologist and figure that out. Or I can maybe just do a deep cervical plexus block, which I look at that as being kind of not just one location / approach, meaning when I was in training, we did it the old-fashioned way where we would draw a line along the foraminal landmarks and then estimate where they are, go in at 3 or 4 different locations to hit the transverse process, hit bone, aspirate, inject. That was a blind approach, which I would never do now. There's no point. With an ultrasound, you could see everything. Then I remember learning a technique where you just infiltrate posterior to the carotid sheath, which is something that people did for carotid endarterectomies, which is also something that I'm not looking to do for this patient. And then there's also the actual nerves as they exit the foramen, forming this deep cervical plexus, which I wanted to get into. So a little anatomy here. The plexus is situated in the groove between the longest capitis and middle scalene muscles, underneath the prevertebral fascia, but not in the interscalene groove, as the anterior scalene muscle is almost absent cranially proximal to C4 or C3. There are 2 loop nerves formed by the union of the adjacent anterior spinal nerves from C2 to C4, give off 4 superficial sensory branches, and the order from cranial to caudate is as follows. And these become the the superficial cervical plexus. The lesser occipital, C2-3, greater auricular, C2-3, transverse cervical, C2-3, and the supraclavicular nerve, C3-4. Don't get confused with supraclavicular brachial plexus or suprascapular nerve. This is supraclavicular nerve. This is the nerve that goes to the clavicle. This is why doing a superficial cervical plexus block will help you with clavicle fractures, and it works great. And many times the orthopedics can't help them, so you could do a lot of good with this nerve block. These nerves initially run posteriorly, then they soon pierce the prevertebral fascia, then they pass through the interfascial space between the sternocleidomastoid and the prevertebral muscles before reaching the skin and superficial structures of the neck via the nerve point of the sternocleidomastoid muscle, which, if you heard my lectures on the superficial cervical plexus, that's where you're hitting it. And this can also help with lesser occipital neuralgia, post-operative neck pain. The superficial branches of the cervical plexus travel a relatively long distance from the paravertebral space to their respective superficial endpoints, including skin, subcutaneous tissues of the neck, and posterior aspect of the head and shoulders. In contrast, the fibers emanating anteromedially from the superior C1-2 and inferior C2-3 roots unite at the level of the omohyoid central tendon to form a loop called the ansa cervicalis, which supplies motor branches to the infrahyoid and sternocleidomastoid muscles with a great degree of variation in its origin and distribution. However, ansa cervicalis has been suspected to have an afferent neuronal composite. The anterior rami of C3 and 4 form a loop, and the branch of this loop joins C5 to give rise to the phrenic nerve. The cervical plexus is known to anastomose with the spinal accessory nerve, hypoglossal nerve, facial vagus nerve, glossopharyngeal nerve, sympathetic trunk. It's shown in a drawing on the reference, which I will post. So there's a lot going on with this plexus here. So my question is, I guess you do to do the nerve block. I suggest to anesthetize C3 and C4. It's sort of a selective nerve root block. You can find these nerves outside their respective foramen, but I suppose doing the deep cervical plexus block could possibly do the same. Now, unfortunately, I did not find any studies quoting deep cervical plexus block for radicular pain at these levels. However, it's a similar approach in terms of a paravertebral injection, which you'll get the nerve root and possibly some of the plexus. The target here is mainly the nerve root C3 and C4 for my particular case, however. So anyway, back to the anatomy and the block. So you're targeting C2 through C4 spinal nerves. It can be achieved either by a single injection or by 3 separate injections. The deep cervical plexus block formed at the paravertebral space can not only block superficial branches, but also the deep branches. So you have to be careful here, by the way, because of the phrenic nerve, right? We mentioned that earlier. And it's mainly used for postoperative pain after neck surgeries involving the infrahyoid or the sternocleidomastoid muscles or carotid endarterectomies. There are reports of using the deep cervical plexus block at C2 or C3, transverse process to treat cervicogenic headaches effectively. The deep plexus block has also been applied during the thyroid and parathyroid surgeries, oral maxillofacial surgeries, and you can get also a lot of complications by injecting here. Intravascular injection, epidural subarachnoid injection, or phrenic nerve palsy. So in my case, I'm going to be very careful with this gentleman. I'm probably going to give him just 1 or 2 mLs. When they're going to the operating room, they're giving a lot more volume, and they're monitoring the patient longer. So if I am going to do a shot for this patient, it's probably going to be a selective nerve root block with 1 or 2 mLs of volume outside the foramen, which you can argue is, if I do multiple levels, is a deep cervical plexus block. However, the goal is not for surgical anesthesia. The goal is really just to treat suspected radicular pain. So I just thought it'd be nice and interesting to mention a unique approach to a problem which I'd say is common, but really not as common at these levels, right? The upper cervical radiculopathies are not as common as the lower cervical radiculopathies, probably because of the weight of the head. It's resting on the lower levels, hence more stress and movement at those levels. So this article I'm going to put in the show notes is great. I think you guys should check it out. There's all sorts of applications for this. I'm looking at the references for this article, and they're talking about using the superficial cervical plexus block for management of herpes zoster in the C3 distribution. They're doing it for carotid endarterectomy, which we all know about. Everybody does that. No big deal. But still, it's nice to hear about it. They display the technique with the landmark approach, old school versus the newer approach. They're even doing cadaver studies in these references with methylene blue to see the spread. So it's an interesting part of the body to work. We don't really do much work up there. I mean, I do a lot of cervical work, but to do this plexus, really, I used to do a lot of it for the awake carotid endarterectomies, where you have a patient squeeze a little squeezy toy on the contralateral side to make sure they're not stroking out. So they're awake, and the surgeon's dissecting out the carotid and doing his endarterectomy. So a lot of cool stuff out there. If you love ultrasound the way I do, check me out. Subscribe to my YouTube channel, Pain Exam, and subscribe to our newsletter. And if you have a real interest in learning ultrasound, come to one of my courses, or if you even want to be an instructor, I am starting to expand and do various sites around the country and around the world, and I'm looking for a team of instructors. But to qualify as an instructor, either you need to be known on a national level, or come visit me, take a course. I need to make sure that you know what you're doing and that you can teach. So once again, just reach out to me through the podcast or through my email or the newsletter. And I'm always happy to talk to people with an interest in pain management, regional anesthesia, who can somehow contribute to my platform as well as help your own. So thanks for listening, and have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.